Well, thank you, Andrew and Conrad. And that was a very lovely introduction. I do want to make one addition to it, and that is that when I won the Fantasy Football League, I was playing against my cardiology fellows, and that was a particular joy I only wish we had been playing for money, really. But it turned out that what they claimed was that I had more time than they did, and that was the reason that I was able to win. So there you are. That's the background of one of my most important accomplishments. So what I want to talk to you about today is, you recall that I talked to you about being a maverick this morning, and I want to apply that now to current times and talk to you about what I believe is a strategy to dislodge coronary artery disease as our nation's #1 killer. I want to start with first principles, giving a biography of atheroma, then talk to you about what I think is the hidden fallacy in our thinking that has crippled our management, and I want to challenge conventional wisdom, and then how I believe we can sharply reduce, and should sharply reduce the incidence of adverse events. So let's look at this graph. It is the most recent data published by the National Institute of Health on mortality for comparing heart disease to cancer. And this is about where I started in cardiology, and since that time we managed to reduce mortality by about 30%. But you can see that in around 2011 or 12, when the latest guidelines came out, and I'm not necessarily blaming the guidelines, but what happened is it started to turn upward again. And now what's happening in the most recent data that is on cancer is that it is turning down again with the development of immunotherapy. So we got very close to no longer being the #1 cause of mortality in the United States, and then we didn't make it. So what I want to ask is, do we need to be mavericky and challenge our current thinking? And I think we do. Let's talk about first the pathogenesis of atherosclerosis. And Iggy, I think you may have to, I'm putting my cursor on that and it's not running. If you could run it for me. Odd thing is it ran earlier. But yeah, it's running now. Okay. So atherosclerosis is a generalized disease, but we're talking heart disease. I think, Iggy, that it's stopped, so click on it one more time. And if we look down in the femoral artery, we should see movement in the femoral artery, and that lets us know that it's running. Okay, you just, I think, started it. Let's see. Yes, okay, there you go. All right, so it's a systemic disease, but we're talking coronary disease, so let's go up into a cross-section of a coronary artery. There's the endothelial cells in the background, and compounds move freely across the blood vessel wall, in and out of the wall, and one of them is cholesterol. But when LDL cholesterol is in abundance or in excess, some of it gets oxidized. And when it gets oxidized, turning yellow there, it stimulates the expression of adhesion molecules, these green guys. And those adhesion molecules attract white cells, particularly monocytes, and pull them right into the blood vessel wall through the gap junctions in the endothelial cells, where those cells begin to gobble up the oxidized LDL. And as we see that, I'm going to ask you a question in a moment. I'm going to take a chance and stop this and then start it again. Okay, so This cell is just engorged with fat. Do any of you remember from your days as one of the greats in pathology what the nickname for that cell is? Maybe it's passed into the ages. We used to call that the foam cell. It was foamy with fat. So there is the foam cell. And the foam cell, or the macrophage, is activated to produce two compounds that are of critical importance to us. One is growth factors, which produce a fibrous cap over this noxious stimuli beneath it. But in addition, ironically, there's a yin and a yang. It also produces collagenases, which can, at certain points along that blood vessel where some atheroma are, erode and erode and erode through that fibrous cap until the cap ruptures, and when it ruptures, platelets form on that surface. And some of the times that is unrecognized clinically, and they get incorporated, and the atheroma grows in size. But other times it goes on to become partially occlusive, and there's a partially occlusive thrombus. And what is the clinical presentation of that partially occlusive thrombus? And STEMI, right. And if it goes on to be completely occlusive, it's an MI. Okay, so that is what we are dealing with. And what I just described to you essentially is something you are very familiar with as a process, because when you were an adolescent, you had the same thing happen on the skin of your face with a pimple. Coronary disease is as simple as a pimple. The pimple is an accumulation of fat that stimulates an aggressive inflammatory response. In some cases, that pimple ruptures, and if it does, a clot forms on that surface. And so you know the process because you've seen it yourself. When it gets incorporated into the blood vessel wall, very often that incorporated thrombus and platelet stuff gets calcified over time, and that becomes important to us in a moment. So let's continue. We know the pathogenesis of atherosclerosis. Let's look at its biography, as Siddhartha Mukherjee said in his wonderful book called The Emperor of All Disease, about cancer. He talked about the biography of cancer. This is the biography of the atheroma. There was, back in the 70s, a study started in Bogalusa, Louisiana, called the Bogalusa Heart Study. Their idea was, we'll measure risk factors in youth, and then we will follow them over the next 40, 50 years and see what happens. Now, when they did that, first thing I want to show you is that a number of those kids died in their 20s violently, and they had postmortems done. And when they did, what they found is they were able to plot the number of risk factors those kids had in their youth at, say, 10 to 15 or so, against what was found in terms of plaque on the aorta, and they found that the more risk factors, the more plaque there was on the surface of the aorta. This is 8-fold more plaque in a person who had, or a child who had grown to have 2 risk factors versus those who had none. A huge difference. And subsequently, there were 3 studies that followed risk factors into the age that you all are, in middle age or early youth, or early adulthood or more, and all 3 of them essentially found the same thing. Bogalusa Heart Study found, no surprise, that the risk factors that were present in the children tracked into adulthood, the cholesterol, etc. And Princeton and the Danish study, both in very large patient populations, found that the metabolic syndrome and the body mass index in youth predicted the presence of adult coronary artery disease. So that was then capped by this study from Steve Nissen and his colleagues at Cleveland Clinic, in which they did a study that probably will never be repeated. They did intravascular ultrasound in 262 donated hearts, the ones that were going in to patients for transplantation, and then they plotted, did they find an atheroma in those blood vessels. Here is a 19-year-old man with just a small atheroma beginning. And here is a 33-year-old woman whose heart was going to be transplanted. And if you got the heart of a 33-year-old lady, you would say, boy, was I lucky. Not so fast, McGillicuddy. Look at this. There is a significant atheroma in that 33-year-old lady. Let's look at the summarized data, and you can see that if you are a cardiology fellow between 20 and 39, you roughly have about a 50% chance of having a lesion of this size in your coronary artery. And so here is the conclusion that you must draw. Atherosclerosis begins in youth. There's really no question about that any longer. And that becomes an important consideration as we move forward. A couple of other things that are worthwhile knowing, and that is, and autopsy studies, which are not done anymore to any great degree, so we don't get to see this anymore, is that plaque rupture is quite common in people who had no symptoms of coronary disease at the time of death. And second, that thrombus incorporation and calcification is found quite frequently in people with and without coronary disease. And by serial angiography, it's apparent that many lesions stay stable and some grow substantially over a relatively short period of time. The thought is that those represent the ones that grow, which are the minority, represent thrombus incorporation and calcification. And this is what serial angiography teaches. I picked the first one published was by a man named Bill Little, and he had serial angiograms before and after a heart attack in a patient. And so he had, in the pre-infarct angiogram, he found that the majority had more than 50% stenosis. That makes sense because probably many of them had angina. But the post-NMI angiogram, more than 50% of the myocardial infarctions were caused by a lesion that was less than 50% stenotic at the time of the pre-infarct angiogram. In other words, the lesions that are causing myocardial infarction, a large number of them, let's just say roughly 50%, are not detectable by symptoms because there is no stenosis that will cause angina. And so that brings us to this critical distinction, which I would assume you're familiar with, and that is the difference between stable plaque and vulnerable plaque, and detecting this is sort of the holy grail of cardiology, which has not yet been achieved. But the stable plaque has a thick fibrous cap over it and has a necrotic core very frequently. But the vulnerable plaque, the one that's going to rupture, has a thin fibrous cap right here, and this, even though the magnitude of the stenosis is perhaps right around 50%, this is the plaque that's going to cause the heart attack. And that is important because of these three stunning statistics that I mentioned to some of you earlier today. I asked, what is the leading cause of death in 45 to 55-year-olds? It is coronary artery disease. And if that 3/4 of the MIs are the first heart attack in that person. And the stunning part about this is that half of the MIs that occur in people who were not previously symptomatic. So what that should say to you is that it's essential that we detect the disease prior to the development of symptoms and manage it, or otherwise we are not going to be able to knock coronary disease off the number one cause of death in the United States. And so what do we do with all this data? Well, you're probably familiar with the quote from Einstein, who said, if you keep doing the same thing over and over again, expecting a different result, that's insanity. What you got to do is get outside the box, stop running around in circles, and come up with an entirely new approach. And if you do, and as I encourage you to do in your research, persist and persist and persist, perhaps you will be able to seize the prize. And if you do, you can be pretty proud of yourself for what you have accomplished, and you will deserve a pat on the head. So let's talk about what can we do. So here is the fallacy that we cardiologists have foisted upon ourselves, and I have battled our leaders trying to get them to come around, and I do believe more and more people are coming around to this point of view. Here is the fallacy. We are talking about 10-year risk when we're talking about a chronic disease that goes throughout a lifetime. You can't talk about a 10-year risk in a 25-year-old because everybody is at low risk, but that 25-year-old at his 10-year risk may be only less than 5% for the next 10 years, but his lifetime risk, if he has 4 risk factors, is 42% by the time he is 55. He's extremely likely to have a cardiac event, even though he has a low 10-year risk. It is not logical to use 10-year risk, as we currently do in cardiology, to assess the risk of a disease that is a lifetime disease. So, how often are people at low short-term risk, but high long-term risk? Here is data from the much-respected Haynes Community Study, 6,000 people, and all they did was calculate short-term risk and long-term risk as a function of age. And this, what I've circled here, is the 30 to 50-year-old age group. The gray is the people who are at low short-term risk, but high long-term risk. It's about 50%. Of both men and, of course, a little bit lower in women, but still the same for women. So they said that 56% of adults are at low short-term, high-term, lifetime cardiovascular risk. And that is a central insight for you as we go forward. So what I would suggest is if you're in the 30s or approaching that, if you're in this age group, look at the person next to you. One of you is at low risk and one of you is at high risk. And have sympathy for the poor devil sitting next to you who is the high risk person. So what can we do about this? Can we find these people who are at low short-term risk, high long-term risk? Well, let's start. Here is data from calcium scanning, 3,700 people, all of whom were asymptomatic, age less than 40, and you can see that a small percentage of them were diabetic. The diabetics have a high prevalence of calcium in the coronary arteries, which is diagnostic of coronary artery disease. There's essentially nothing else that will do it, with some very, very minimal exceptions. But the non-diabetics, only a quarter. And there's the problem. If we try to start doing calcium scans in our people around the age of 40 or a little less, we're going to be spending a lot of money on negative tests because 3 out of 4 roughly will have a negative test. So it isn't cost effective to scan every asymptomatic middle-aged adult. That can't be done. But look at this next set of data from the Cardia study, which should be on each of our minds. This is a study of 3,000 people who had a remarkable sequence of studies. They had the risk factor analysis in youth. Then, at average age of 40, they had a calcium scan. And then, after that, they were followed for 12 years. 309, only 10% has a positive calcium scan at age 40. However, any calcium versus no calcium, any calcium had a 5-fold greater risk of a cardiac event. That was a low risk, high risk, low short-term risk, high long-term risk population. And if you had a calcium score of 100, you had a stunning rate of death in the next 12 years, starting at age 40. 22% of these people had died in the next 12 years. You have in your hands a tool here that now, in the next data that I want to draw to your attention is the crucial insight from this is that if you chose only the people whose risk score, Framingham risk score, was above the median, the upper 50% of risk, then half of the calcium scores in that population were positive. Now you have an investigative tool that will allow you to identify high long-term risk people with a test that at least is positive half of the time. You say, well, I don't even want to spend that much money. I want to move the scale further. You could, instead of taking a risk factor score above the median, take it 10% above the median, have less calcium scans. But the point is, you have tools here. I think doing a calcium scan in the people who are above the median is the right way to go. But what I'm trying to also emphasize is this is a flexible criteria that depends on how many calcium scans you're willing to do. This is what we do at Cedars. So the idea that I'm proposing to you to consider, which is a maverick idea relative to the guidelines that you are dealing with right now, is we're going to try to move coronary disease from here with the plaque rupture back here to the asymptomatic phase, and we're going to try to identify those short-term, low risk, high long-term risk people and intervene in some way before they develop a catastrophe. So calcium scans in patients with high risk factors predicts pre-symptomatic coronary disease and provides a rationale for therapy. Let's talk then, we have a rationale for how to go about detecting coronary disease. And now talk about how we take that information and reduce cardiac adverse events now and in the future. And fundamentally, there's no surprise here. It's lifestyle modification and lipid lowering. But once again, I have to disagree with our guidelines and our way of thinking about this. So here's the mavericky challenge conventional wisdom thinking. This is data from recently published by one of my former fellows, Greg Thomas. He went around the world and did calcium scans all over the place. One of the places he went to was the Bolivian jungle, where they did calcium scans on the Tsimane, that's the way you pronounce it, Tsimane tribe of the Bolivian jungle. Look at the calcium scans. Here are, as a function of age. This is the U.S. population with different race categories. This is the Asian population. Down here is the Tsimane. They don't get coronary disease. They don't get coronary disease. And their diet is catfish, piranhas, wild pig, wild fruits, nuts, rice, plantains, corn, etc. It's a vegetable, a lot of vegetable. And their life, as opposed to ours, is 10% sedentary, whereas ours is 54%. So they are living the way the good Lord meant us to live back when he first created us. The conclusion I draw from this data and a lot of others is that coronary disease is actually a preventable lifestyle disease. And that allows me to then identify the person least likely to have a coronary. And that turns out to be an effete vegetarian of Bolivian ascent who's never met a deadline in his life, is scrawny and unathletic, but is constantly flexing his puny muscles, washes down his leafy greens with a glass of Zinfandel. And last night we didn't have Zin, did we? We had Pinot Noir, yes, but that'll do. Abhors smoke, even from candles, and has been taking omega-3s, resveratrol, aspirin, and Repatha ever since his prophylactic castration, following the death of his 102-year-old father. So there's the kind of patient you'd like to have. But if coronary disease is a dietary disease, what's the best diet? And this is the best data I think we have so far. The Mediterranean diet was put head-to-head with the low-fat diet, which we in cardiology had for years advocated. And there was a 30% reduction in cardiac events in those who had the Mediterranean diet. As a generality, I don't think we need necessarily to talk about the Mediterranean diet and what exactly is in it. What is good in the diet is fruits, vegetables, nuts, olive oil, fish, and wine in moderation. What's very bad is trans fats and simple sugars. I think all those are widely agreed to, and not good, at least, is animal fat and red meat. I'm not sure how bad it is, but it certainly is not, doesn't get to be called good. So that is the kind of diet that we should be following. But let's face it, the Mediterranean diet alone is not likely to succeed because we're trying that already and we're not making great headway. And here is, I think, the reason. This is stunning data. This is the rate of obesity in children. And the black line is the sum of children of all age. The others are different age groups. And what you see is between roughly 1970 and roughly today, there has been a threefold tripling of obesity in children from, let's call it 5% to 15%. Of children. And what that translates, as you now know, because of the Bogalusa data that I showed you, is that that will translate into adult obesity. And here's what's happened. This graph back in the 70s was all yellow. Now, in our southern states, adjacent to Florida, over 35% of the citizens of those states are obese. So what are we going to do about this? Well, I am moving to Colorado, so I pretty much got it covered there. But here's what's happened, and this you need to know about because it is happening this year. This year, the American Heart Association and the American Academy of Pediatrics came out in their guidelines and stated flatly, obesity in adolescents is a cardiovascular risk factor. Of course, you and I knew that from the previous studies that I showed you, but now it's in print and it's your official organization saying that that is true. And just this month, last week, publication of the WHO guidelines, which says remarkably that children of 2 to 4 years of age should not have more than an hour of sedentary screen time each day. What they're trying to do is get us to moving again instead of looking at our, does anybody have their cell phone out and feels guilty right this moment? But in any case, that's what they're after. They're trying to get us to move and to change our diet. And that leads us to what is going to be, you should be aware of, the next big cardiovascular war, and it is going to be a battle with what's called big soda. And it is our two of our top medical groups, the American Heart and the American Academy of Pediatrics, last month came out with a statement that we should now have tax on soda and tax and curbs on advertising of sugar drinks. Very aggressive regulation. And since you're a member of the AHA, I think probably, even though you may be averse to regulation, I am going to go with this. I think this is probably what we have to do because we are facing such difficulty. This week in California, the two lobbying groups, the California Medical Association, faced off against the American Beverage Association over two bills, one to tax soda and one to limit serving size, and they failed in the California legislature. So that's where we are in terms of the war with big soda. Cardiology is coming out on one side, medicine is coming out on one side, and it's going to face a very significant opposition from big soda. So how significant is this? This is 37,000 men and 80,000 women studied over a recent period, and they took a diet history and then just plotted cardiovascular mortality relative to soda consumption. There was a monotonic increase in the consumption of cardiovascular mortality according to the reported amounts of soda. There's roughly a 10% increase in with each drink that they had, and in those who drank more than 2 sodas per day, there was a 31% increase in cardiovascular mortality. This is serious business, and it is an opening for us to bring cardiovascular disease under control if we want to go the regulatory route. This article in this month's circulation said that over the next 20 years, the FDA's 2020 added sugar labeling could save nearly 1 million cases of cardiovascular disease and type 2 diabetes, and also save a lot of money. The FDA's added sugar labeling is they tell you what's in the whatever compound it is, and then they tell you whatever product you're buying, and then they tell you what additional sugar has been added to that product for your consumption. So this is what the FDA is doing about this. So this is an attack on obesity and cardiovascular disease that I think we must support, and is likely would be effective at. But of course, this is my tunnel vision cardiology. It's not nature's greatest battle. Nature's greatest battle is this. In the beginning, God created the heavens and earth and populated the earth with broccoli and cauliflower and spinach and green and yellow vegetables of all kinds, so that man and woman would live long and healthy lives. Then, using God's great gifts, Satan created Ben and Jerry's ice cream and Krispy Kreme donuts. And Satan said, "You want chocolate with that?" And man said, "Yes." And woman said, "And add some sprinkles." They gained 10 pounds, and Satan smiled. Then God brought forth running shoes so that his children might lose those extra pounds. And Satan gave cable TV with a remote control so man would not have to toil changing the channels. And man and woman rested and gained pounds. God then gave lean beef so that man might consume fewer calories, yet satisfy his appetite. And Satan created McDonald's and its 99% cheeseburger. "Some fries with that?" he asked. And man replied, "Yes," and supersized them. And Satan said, "It is good." And man went into cardiac arrest. God sighed and created quadruple bypass surgery. Then Satan created HMOs. So, diet alone isn't going to do it. We got to attack it, but realistically, we're going to have to do more than that for our patients. Diet and exercise alone is going to be insufficient for our patients, but we really got to focus on it nonetheless. And here is some data that is really enlightening. It's an experiment of nature that lets us know what would happen if we lowered the LDL over a lifetime. And that happens with the PCSK9 mutation, which occurs in about 3% of people. And so in this study, I think it was the ERIC study, they have 15-year follow-up in the people who had a PCSK9 mutation and those who didn't, compare the two. The LDL was only 19% lower in the PCSK9 group, but the PCSK9 disabled group, but it resulted in a more than 50% reduction in cardiac, 50% reduction, with only a 20% reduction in LDL over a lifetime. That gives you a sense of the impact if you started earlier with what you're doing. And I use this in my own thinking of saying this is why we have to start earlier on what we're doing. The implication is that coronary disease is a slowly progressive, preventable disease if prevention begins at an earlier age. And so what do we do about that? Well, as recommended by the National Cholesterol Education Guidelines, you should be doing a lipid profile in 10-year-olds and again in 20-year-olds. And what you're trying to do is identify those people who fall into the low short-term risk, high long-term risk population. And then you've got to think about what are you going to do in terms of management. And of course, diet and exercise come number one. In some of them, you will choose to do a calcium scan if they're in the 40-year-old range, ultimately, and then further stratify by whether they have a positive or negative scan. So what is the normal LDL in men? This was something I published back in 2010, and I don't think many people believed it. But I believe it is true, and I think people are coming around to see this with the most recent clinical trials as probably being true. What do these three groups, wild animals and primates, humans age 4 to 12, and hunter-gatherers all have in common from a cardiology standpoint? Well, if you think about it, you would get it. It is none of them ever have a heart attack. None of them ever have a heart attack, just like the Simani. And here's our average LDL in the United States, 120. You cannot determine the normal level of LDL by taking the people without known coronary disease and drawing a frequency distribution and then picking one or two standard deviations. And the reason is the people that you define as having no coronary disease actually have coronary disease. So you cannot use a normal population the way you can for sodium or potassium or other things. I believe that Mother Nature, unless we are different than all the rest of the animals, I mean, this includes rhinoceroses and pigs and monkeys and all kinds of animals in the wild. And I believe that the normal range of LDL cholesterol is in the range of 30 to 60 for humans, and we just have got way outside that number. And because of that, I think we ought to, as a first therapeutic principle like we do in everything else, we ought to make our management of coronary disease should aim to return the abnormal LDL to the normal range. That's just a basic principle of medicine, and it applies in this case as well. And what happens if you were to bring that LDL down? This is from the Fourier trial, which was a treatment of PCSK9, not really advocating the PCSK9, but rather saying that what this shows is that lower is better, and it is better in terms of cardiac events on this axis, all the way down into the 20s to 40s, and there was no safety issue. So apparently, therapeutically dropping LDL into this range with a PCSK9 inhibitor results in a substantial reduction in cardiac events over just 2 years, 25% reduction in risk if you were to go down into that range. So that's what I think we ought to be doing, except we may not have potent enough drugs to do that. So my feeling is that you should, when you decide a person has coronary disease, you should treat with a generic statin, aiming for an LDL in the range of 50 to 70. When coronary disease is known to be present, or even not known to be present. It doesn't make a difference. It's the same disease, except that one has presented with a symptomatic greater than 50% stenosis, and the other has not. But it's the same biology, and the people with the non-flow-limiting stenosis are at equal risk to those with a flow-limiting stenosis. So this is, I think everybody ought to be going down into this range. Now, if you can't get down to the LDL range, and this is only in people with coronary disease, I think you should be aware that PCSK9, it's certainly getting more use now, but the problem is with the PCSK9 inhibitors, it's been reduced now to $5,800 a year from $14,000. So it's still expensive, but probably reachable. But the problem, in addition, is it's got to be injected frequently. Here is a different, that's a monoclonal antibody. Here is a newly developed and studied RNA inhibitor of PCSK9 synthesis. So it's a PCSK9 inhibitor, but by a different mechanism. It only has to be injected on day 1 and 9, and then every 6 months. Here's the data on LDL lowering. It is essentially comparable to the PCSK9 monoclonal antibodies, but it has not yet had a clinical trial reported. I would imagine that will appear in the next year or so, and you will then have a different kind of PCSK9 inhibitor, and we'll just have to see how they price it. But from the standpoint of practicality, it seems to me to be much more appealing, could conceivably drive down the price of PCSK9 monoclonal antibodies a lot further, since this would be quite competitive from a patient preference point of view. There were no safety issues in this trial. Another alternative you need to be aware of, because this one has a substantial amount of appeal as well. It's a drug called bempedoic acid, and it is proximal. It inhibits HMG-CoA reductase inhibition like a statin does, but it's proximal to the action of the statin. And when combined with a statin, it works independently. So here's bempedoic acid now combined with ezetimibe, and one of the pharmaceutical companies is going to be pushing this very hard. This, I believe it is, I'm not sure which company it is actually. So here is the two combined, a 35% reduction in LDL in people who were on maximally tolerated statin. That's a whopping reduction when you're already on a maximally tolerated statin. And you can see ezetimibe and bempedoic acid alone don't do that, but in combination they get close to being additive. And they also inhibit or they reduce C-reactive protein, suggesting it may have an effect on inflammation. And in the statin intolerant group in this trial, the LDL cholesterol was reduced by 43%. So this is a probably very important drug that will appear in the next year or so, and you should be aware of it. The one that I don't know about is this remarkable study with a drug called Vascepa. It is essentially pure eicosapentaenoic acid, fish oil. And this was in 8,000 people over 5 years on maximally tolerated statin, 60% of whom were diabetic. They have to take the drug BID, and it was against placebo. And you can see there is a whopping reduction. This is about a 35% reduction in cardiac events with Vascepa. And it doesn't look like it was due to triglyceride lowering, although it did lower triglyceride, and there's no question that fatty acids do that. Triglyceride was elevated and fell to elevated. And so many of us think that perhaps this is an anti-inflammatory effect rather than a triglyceride lowering effect, particularly because triglyceride lowering drugs have not been very successful in cardiology. So I believe that I'm not quite sure what to do with Vascepa. Should we be giving it to people with coronary disease and not diabetic? Right now, what we are saying to each other is take the people who were in this trial, take the diabetics who have elevated triglyceride, and give Vascepa to them, and we'll wait to see more data for the rest of it. So in the past 2 years, here's what I think we have that we didn't have, and I'd like you to be thinking about and aware of, even though your mentors in national cardiology do not necessarily agree in terms of writing the guidelines. We have a viable strategy for detecting and treating coronary disease prior to symptoms. Identify the high risk factor people, identify the people in that group that have calcium, and if they have calcium, even if it's low, they have an elevated risk of cardiac events, and treat them with a statin. Try to get it as low as you can. It's okay to go to a high dose of statin, and try to get down to at least 70. 50 is better if it gets that low, so don't worry if it goes low. And what we know is that there's no particular short-term risk with that. We don't really know anything more than short-term, so we have to be honest. Getting down to that level hasn't been possible before. And then after statins, we have potent new secondary drugs that are on the horizon. We'll just have to see what they bring to us. So my challenge to conventional wisdom in our epic battle with coronary disease is a strategy that I believe is viable given that the cost is acceptable to your patients, the side effects are minimal with your patients, and of course that will rule out some of the people taking statins, and the patient is willing to take a medication even though they may not have symptoms. And given those caveats, I think that what we're dealing with is a slowly progressive dietary disease that begins in childhood. We need to begin risk factor screening in youth. We need to participate in a preemptive attack on childhood obesity. That is probably the number one cause for that upturn in cardiac mortality that has occurred in the past decade or 8 years. The second being that we are not treating early enough and aggressively enough. Calcium scan after 40 focused on above average by risk. If the person has a calcium score greater than 0, call that coronary disease and treat it. If there's no if there's no calcium, that gives you the right to not give statins, even though there may be other factors. And recognize that lower is better. Probably 70 is a reasonable target at the present time, even if, and 30 to 50 is fine if they happen to get down to that level, which probably many of them will not. And the likely outcome, if these 5 items were initiated in the United States, is that this would dislodge coronary disease as the #1 killer of 45 to 50-year-olds, which it is today. So what should you do? Well, you know, I recognize that you got the pharmaceutical reps coming in, waving their hands and saying, give this drug, don't give that drug, mine is better. And then you got the third-party payers, and they say, no, that isn't as good as this because that costs more, and so you ought to give this. And then you got the experts and the pseudo-experts like me coming in and waving their hands and telling you what to do. Well, so what should you do? My recommendation is you be the big cat and you make the final decision on all of this. So thank you very much for having me here to my end.